I'd like to thank you for inviting me here today. My name's Dr. Deborah Gentile. I'm a pediatric allergy and asthma expert, and I provide care for both children and adults at the Pediatric Alliance right now. I also have an academic appointment at the Duquesne University within their School of Pharmacy. And over the last 5 years, through Duquesne, we've had foundation funding to do a lot of work looking at air pollution issues, health issues in children, both in Clairton and in Braddock. And additionally, we've started some school-based care clinics for the children we found, so I'm going to tell you about that today. I'm going to focus on asthma. It's not the only disease that's affected by air quality, and I'll touch upon that at the end. Asthma is a disease of disparities, and it disproportionately affects minorities and the poor. Among children, asthma is one of the top causes of missed school days, accounting for 14 million missed school days annually. Childhood asthma impacts the ability to learn, participate in physical activity, and to socialize. Consequently, asthma can potentially impair post-secondary education and career opportunities, as well as detrimentally affect long-term health outcomes by contributing to physical inactivity and obesity. Air pollution is not the only thing that triggers asthma, just like it's not the only thing that triggers cardiac disease. These diseases are multifactorial. Asthma is multifactorial. It's caused by an interaction between having the right genetic makeup as well as having the right environmental exposures. These include things like respiratory infections, allergies, outdoor air pollution, nutrition, and even psychological stress. And there can be interactions between these that amplify what goes on. And we also think the timing of exposure is very important. There's recent data that shows that women, while they're expecting their child, during that second and third trimester, exposure to air pollution can actually impact on that child having asthma. So this is very serious. We know that most children who develop asthma manifest symptoms within those first 2 years of life, and we think exposures during that time period are important. Again, my research team at Duquesne has recently evaluated asthma prevalence and outcomes in about 1,200 school-aged children that reside near point sources of air pollution in the Pittsburgh region. Approximately 50% of the participants were male, 52% were African American, and 61% had public health insurance, which is a marker of lower socioeconomic status. 82% of the children who participated reside in the prevailing wind direction of their nearest point source of outdoor air pollution, and their mean linear distance of their home from that point source of pollution is only 2.2 miles. We use data that's collected by the mobile monitoring platform that Dr. Albert Presto operates at Carnegie Mellon University. He has very sophisticated equipment on these vans that can go around street by street and get the actual pollution levels down to the street address. They take the van out in all types of different temperatures and different environmental changes and try to get a very good number of what that is. So we used data that he's collected. We actually found that the annual mean mean PM 2.5 exposure of all the children that we studied, their average exposure was 11.9 micrograms per meter cube. That's barely below the Environmental Protection Agency limit of 12. That's the mean. That's what half of them have and what the other half don't. And we actually know that 30% of them are exposed to above that level. So, in spite of us having cleaned up the air, we still have issues. These kids are getting high exposures. In that group of 1,200 children, the overall prevalence of physician-diagnosed asthma was 22.5%. This is more than double the national and state rates of 9% and 10% respectively. We've taken into account, we know more boys have asthma, we know more African Americans have asthma, we know more poorer children have asthma. After we had taken account for these things and adjust for those, we found that exposure to the higher levels of the PM 2.5 was associated with a 1.6 times increased odds of having asthma diagnosis. We looked at other factors. We looked at tobacco smoke exposure. We also looked at obesity. These are things that get attention as to contributing to asthma. In this cohort of children, once we adjusted again for those demographic factors, these were not playing a factor. What they were being driven by with their asthma diagnosis is the outdoor air pollution they're exposed to. Among the children who do have a history of physician-diagnosed asthma, we look at whether their disease is controlled or uncontrolled. That means, are they able to run outside and play and do everyday things? Can they sleep at night? Do they have to be using their inhaler? What we found was the rate of uncontrolled disease was almost 60%, and that's much higher than a national rate of 40% and a state rate of 28%. Again, once we adjust for gender, race, and poverty, the higher levels of PM2.5 were associated with nearly a 5 times increased odds ratio of having uncontrolled asthma. And again, that's only with the PM2.5. When we do these adjustments and we're looking at whether obesity or tobacco smoke had an effect on these kids, it did not. It again was the pollution driving them. Clairton was one of the schools that participated in this project. 213 elementary school children from Clairton enrolled. 49% were male, 63% were African American, and 92% have public health insurance, which is again our marker of being poor. The mean residential distance of these children's homes from the Clairton Coke facility was 1 mile. Using data again collected from CMU's monitoring platform that goes around and again gets the pollution level right to their street address, their mean annual PM2.5 exposure was 13.1 micrograms per meter cubed, and this is above the EPA limit of 12 micrograms per meter cubed. Additionally, 60% of the children who participated were above that EPA threshold of 12. These kids are breathing this every day. Again, it's just, these are the facts. The prevalence of physician-diagnosed asthma among these Clairton school children was 18.4%, again, as compared to a national rate of 9 and a state rate of 10, basically double. Additionally, we found another 15% that we screened for possible asthma. It's very likely they have asthma, they just haven't been diagnosed by a physician yet. They have symptoms and signs that are consistent with asthma, but no formal diagnosis. And again, of those that have known physician-diagnosed asthma, 64% were poorly controlled as compared to the national rate of 38% and a state rate of 27%. Now, after identifying these high asthma prevalence rates and poor rates of control, our research team began to conduct school-based clinics in an effort to improve health outcomes. To date, we've enrolled approximately 75 school children from Clairton, Woodland Hills, and Propel Hazelwood. Analysis of the results from the first 50 children enrolled, and these were from Clairton as well as Woodland Hills, showed significant improvement in visit compliance, asthma knowledge, and asthma control after enrollment and participation in our program. We currently have 15 school children enrolled in the program at Clairton. These children are seen for regular visits based on the severity of their asthma. When we first start out, we see everyone at 2 weeks visits. Usually by the 3rd visit, we have them having their asthma controlled. They understand the education. They understand to use their controllers. Approximately half the children enrolled have mild intermittent asthma and do not require daily controller. The other half have persistent asthma, and they required me to adjust or add on their daily controller medicines and visits. At one of our routine visits on November 28th of 2018 and December 12th, 2018, we evaluated all these patients. I saw them just as though they would come and see me in my office. We do breathing tests on them, just like you would have done in my office. I examine them, and we actually do asthma control tests to see if they're controlled. All 15 of these children were controlled at visits on November 28th and December 12th. After the fire occurred at the Clairton Coke Works facility on December 28th, multiple exceedances of SO2 admissions, which are known to exacerbate asthma, and the emission levels that were the spikes are known to exacerbate asthma. Once you're above 75, you're going to exacerbate it. They were in the 80s, you saw that. So those were documented. Subsequently, our next regularly scheduled asthma follow-up visit at Clairton was on January 14th. Unfortunately, let me first say 14 of the 15 students participating in the program were in school that day, so we could see 14 of them. None of the children that we evaluated had respiratory illnesses, and that's important because at this time of the year, that would be what would be driving asthma. We don't have pollens out there driving seasonal asthma. Unfortunately, 5 of the 14 children we saw that day, which is 36% of the participants, had significant decreases in their lung function. And again, I'm using the equipment I would use if you came to see me in my office. 2 of these children had documented increased use of albuterol rescue medication since school resumed in January. Because I'm able to pull the school nurse reports, I can see that these kids were going down. They needed to use their rescue, whereas before they were dismissed at the end of December, they weren't using it. Both of these children were sick enough that I had to place them on oral steroids to control their worsening asthma. So we had 5 with decreased lung function, 2 with worsening asthma that really needed to go on intensified controller therapy of oral steroids. The other ones I opted to follow and see how they did. In comparison, we had 9 children at the same time enrolled in the same asthma program in Hazelwood. All 9 were seen for a regularly scheduled visit on January 7th. None of them had decreases in their lung function. None of them reported increased albuterol use or increased asthma symptoms. One patient did report a recent respiratory infection and was using albuterol prophylactically for that, but her lung function was normal and I did not need to prescribe any additional medications. These results, they're small, but this is real time and we're there with these kids. These results show a temporal relationship between these SO2 exceedances and deteriorating asthma control in children residing near the Clairton Coke facility. These deteriorations are not due to other common asthma triggers. None of the children from Clairton had a recent viral respiratory illness. None of them had recent changes in indoor exposure, such as secondhand smoke or allergens. Again, we're out of pollen allergy seasons. That's not contributing. The absence of asthma deterioration in the Hazelwood cohort actually suggests that the local exceedances in SO2 and Clairton contributed to the worsening of asthma in those school children. These results clearly illustrate the need for continued air pollution monitoring and also demonstrate the strong need for a system to warn at-risk individuals of harmful exposures so that they can take timely precautions to protect their health. In summary, the residents of Clairton and the Mon Valley are exposed to high levels of pollution that impact health outcomes, including but not limited to asthma. They also impact COPD, heart disease, malignancy, and also lead to premature mortality. This exposure has been ongoing for decades, and now superimposed on that are the recent exceedances in SO2 following the Clairton Coke Works fires, as well as the delayed notification of these exceedances to the public. Additionally, for approximately 1 month now, the residents of the Mon Valley have been under an alert from the Allegheny County Health Department, encouraging them, especially sensitive populations, to limit their outdoor activities until further notice. Many affected residents don't understand what this warning means, and they need advice that's a bit more specific and timely. Also, I think it's very impractical to ask these residents to limit outdoor activities for such an indeterminate amount of time. And also, these children, as part of their health, they need to be outside running and playing. We're telling them they can't go out and run and play because the air is too poor right now. That's going to affect their long-term health. Sports seasons are around the corner. It's going to be baseball season, track season, and these kids aren't going to be able to go out and play and do what they should be able to do because of this. In closing, I think there's 3 areas that need to be addressed. First, policy change must occur to ensure that there's reduction of exposure to outdoor air pollution. Second, an efficient and effective protocol must be developed to ensure that the public is made aware in a timely manner of both acute threats to public health, and they also need to be advised on specific appropriate action to undertake to ensure the protection of their own health. Finally, the community members need to be heard. The community members are the ones who are at risk of these problems. They're the ones that live here. They need to be supported by all of us. We have to support them in their efforts. They need to be allowed to come in and voice their concerns and say what changes they'd like to see and be allowed to participate in affecting those changes. Thank you very much for allowing me to testify.